Hello, and thank you for joining us today to talk about pelvic floor dysfunction on our Facebook live chat. I am Dr. Lioudmila Lipetskaia, and I have a very long title, Female Pelvic Medicine and Reconstructive Surgeon, aka Urogynecologist. And I'm here along with Dr. Bruckler and Michele Stroud, and I'm going to let them introduce themselves.
Hi, I'm Dr. Paula Bruckler. I'm one of the obstetrician gynecologists here at Cooper. And we're here today to talk about pelvic floor disorders. And Michele, introduce yourself.
Hi, I'm Michele Stroud. I'm a physical therapist, and I've been with Cooper for the past 20 years. I've focused on pelvic therapy for the past 16 years and enjoy it very much and love to collaborate together with Dr. Bruckler and Dr. Lipetskaia. And today we're going to talk about some of the symptoms that you may have that would warrant maybe a trip to your urogynecologist or gynecologist, because a lot of times women have symptoms that they kind of suffer or live with for a long period of time and don't seek help for, and there is help available.
So we're just going to start from the basics. What are the symptoms? So urogynecology, pelvic floor dysfunction, this is all the words of what we're dealing with, but what does it mean on your level? So what I do and take care of the patients with problems with urination, and it can be different problems. My patient might have problems with holding urine, or we just do too many trips to the bathroom, or we have that gotta go, cannot make our time to bathroom feeling. There's also problems with bulge. Sometimes there is this condition called Prolapse, so sensation of vagina falling out, and this is another example of the pelvic floor dysfunction. Bowel issues, either leakage or inability to empty your bowels or into your bladder. That falls onto the category of the problems I'm dealing with that. And this is very, very common. Believe it or not, about 25% of women are affected on that. And of course, that gets more and more prevalent as women grow older. So a good chunk of my population patients is anywhere between 40 to 60, but I treat patients as young as 18, and my oldest patient was 99. So we're going to talk to Dr. Bruckler, who's a general OB-GYN, and she takes care of the women who do and don't have the problems like pelvic floor dysfunction. So how do you get one?
So you see me every year for all your problems, your general GYN visit, and at that time it's one of the important visits to sort of say what's normal, what's not normal. So we can talk about whether, after having a baby, if you're still having some urinary symptoms, whether there's urgency, whether there's leakage of urine, not emptying your bladder, and we can help you decipher whether those symptoms are normal from a postpartum, having a baby, normal from aging, and try to see whether this is normal and something that we can deal with in my office, or it's something that requires somebody with more expertise like Dr. Lipetskaia. So some of the symptoms that, some of the things that we sort of work through, like what makes you prone to having any of these pelvic floor disorders. Like I said, one of the major ones everybody knows is childbirth. So having one baby, having many babies, any of those can cause those problems. Menopause is a big one, and a lot of times women in menopause don't want to talk about all those symptoms. They're uncomfortable, and they live with things that we can fix, that we can help them with. If you have previous pelvic surgery, if you have somebody that's weightlifting, and a lot of intra-abdominal pressure type exercises can make you leak urine, and we can help you with that. Genetics, there are things that it doesn't matter if you didn't have baby, but mom had prolapse, you might be prone to have the same issues. So my job is to sort of help you decide whether you need to go to Dr. Lipetskaia or do you need to go to Michele.
And Michele is a lovely physical therapist, typically my first stop on the way of treating those conditions. So then I refer my patients to her. I always get this question, so what is she going to do to me? So I'm going to let Michele this is your time to shine, and tell what is to expect.
Oh, well, that is the first question that I get asked, because I usually contact my patients and set them up in my schedule, and the first thing they say is, what is pelvic floor therapy? And I have never heard of it before. They had no idea that there was such a thing. So the way I explain it to them is that we are going to take a muscle that is not functioning well, and we're going to teach it how to function in the context of your body again. We want to teach it to remember what it used to know how to do before you had a baby, or before you went through menopause, or before you had some kind of pelvic trauma that cause you to disconnect from your pelvic floor. So it's really reintegrating your pelvic floor into doing what it used to be able to do, supporting your pelvic organs, preventing you from leaking, whether that's urine or otherwise. Teaching the muscles how to relax, that's a big thing, because a lot of the time people think they're coming to see me to do Kegels, and that's not always the case. That's a very, very small part of what I teach them to do. It's important, but it's not by any means the main thing that we work on in pelvic therapy. So it's basically just teaching a woman how to reconnect with her pelvic floor and how to make it do what it's supposed to do and what it should be doing for them.
And this is what I typically tell my patients. What she does is very complicated, but see her as your personal trainer for your pelvic floor muscles. So you know how you go in and you're trying to build your muscles and you can actually hurt yourself, and you do go to the gym and you hire yourself a personal trainer so you don't do things wrong. Michele is your personal trainer. So after spending time with her, you will be able to strengthen your muscles or relax your muscles or do whatever is the right thing for your body. But a lot of time, this is the first step to build a good foundation for any kind of reconstructions you're going to go up for. What I hear a lot of, and Dr. Bruckler was talking about that, my patients come and say, okay, so it's happening to me, I'm leaking urine, I have bulge, why, and what could have I done to prevent it in the past? So one of the questions is C-section, because Paula mentioned that childbirth is related to the pelvic floor dysfunction. That is true, but just a little bit of information about the C-section, and was it worth it to have a C-section? So I'm just going to let Dr. Bruckler answer.
So, right, that's one of the questions that comes up a lot. Is it worth to have a C-section to prevent any of these things happening? And so the risk, everything that we do in medicine is risk outweighed benefits. The risk of a C-section, it's an intra-abdominal surgery. The research has not said that it's worth doing that because it does not prevent any pelvic floor dysfunction. Although you may not have the tears that you may or may not have from a vaginal delivery, you still carry a baby for 9 months. It does cause some stretching, and you can still get those symptoms of, pelvic floor dysfunction even if you had a C-section. So, for patients, that's something that I screen for, whether you had a vaginal delivery or a C-section when they come to see me for their annual exams.
So that is true. So having C-section alone for the indication of preventing yourself from having pelvic floor dysfunction is probably not the best solution. But there are some other things you can do to prevent yourself from the damage the pelvic floor sustains during childbirth. And if you see Michele before you have a child, she can teach you why. So why don't you tell us a little bit about what you can do to minimize the impact of the childbirth on the pelvic floor?
Wow. The way I look at pregnancy and the way I teach women to think about pregnancy it's the marathon for your pelvic floor that you never trained for. So you just show up at the starting line with a pair of sneakers and you're like, okay. So we don't do a whole lot to prepare ourselves for a baby other than do the important things like go in for prenatal visits, but we don't do very much in terms of musculoskeletal preparation. So even doing things like Kegels correctly, where you're contracting and fully releasing your muscles, certainly maintaining flexibility of your lower extremities, your hips, and your lumbar spine, because your pelvis is grand central station and everything connects here. So there are no isolated pelvic floor muscle problems without involving the areas above and below. So maintaining flexibility, strength, and stability throughout the core. Hips and pelvis are very important. Dr. Bruckler and I were talking before our session about perineal massage, teaching either a partner or the woman that's pregnant to massage the perineum, just to stretch that area to prepare it for birth and for baby delivery. And then doing Kegels, again, is so important. Just like you would go to physical therapy after you had knee replacement surgery, you want to get those muscles working as quickly as possible after that trauma so that they can start to reconnect neurologically and start to work again. So just preparing them with stretching exercises, core stability exercises, Kegel exercises, and perineal massage.
So this is basically when I have a patient who about to go birth. I always tell them, you go for this birth labor classes, right? They teach you how to take care of your baby. They actually should be talking about how to take care of your pelvic floor as well. So a little bit of education on that side. And if you look at other countries, like in France, for example, they have pelvic floor therapy for postpartum patients. certain things during the labor predispose you for more pelvic floor damage than others, and I'm going to let Dr. Bruckler, who is the lovely obstetrician, to tell us about this.
So, prolonged labor is going to be one of those things that sort of sets you up for any sort of pelvic floor dysfunction. 3rd and 4th degree tears, sometimes if you have a really large baby, if you have things like forceps, are things that are going to predispose you to have any sort of pelvic floor dysfunction. And Michele and I were talking about that prior to the meeting, that, maybe we should screen these women and offer them at their 6-week visit postpartum, hey, are you interested in seeing somebody like Michele to sort of help you? There is a lot of scar tissue that builds up after you do a vaginal repair, and she can help with, some of the pain with intercourse that can happen after that.
That's a big issue.
Right.
Yeah, and women don't usually talk about that.
Right, nobody wants to talk about
see
it.
you or you. They'll say, it really does hurt when I have sex.
Right.
And,
so,
they're kind of embarrassed, or they don't feel like it's a conversation they can have with their friends.
Exactly.
But I think women now are doing it more.
Right.
But yeah,
so
I would love that.
We'll talk about it.
Yeah, so one of the unintended consequences of giving birth can be some problems with pain during intercourse later on. And Michele would be probably the first person to work on the muscle portion of that. Sometimes it does require revision, and especially it depends how much of laceration was sustained and damage to the pelvic floor during the labor. But let's say the question comes up sometimes, so I had some pelvic floor dysfunction after my first baby. Should I have C-section to prevent my next one? And how do you counsel your patients on that?
So it depends. So depends on the injury. So for a woman that's had a severe injury, like a 4th degree vaginal tears, we can offer them a C-section to prevent that from happening again, because it's more likely to happen once it's happened once.
So what typically happens, like if you, let's say, birth time was pretty substantial, and Dr. Bruckler takes care of that, and then she refers the patient for me to see, and a lot of times just people asking, like, what's going to happen on that exam. So what I do during my personal exam, and you go and actually see some specialist, which this is what I am, it takes about training to develop some knowledge in the Urogynecologist and a special fellowship, and then, as years of experience. So when I see my patients, what I tell them is, we're going to do the exam, and it's majority of the exam is actually very resembling what Dr. Bruckler does. So I do speculum exam to look and inspect the vaginal walls, but I also check something which is pertinent to Michele. I check the muscle strength, I check the tension of the muscles. Sometimes the pain is related to the intercourse, can be related to some muscle tightening, and that is definitely down to the pelvic floor muscle high tone dysfunction. This is the special name it carries, and we can address that through the physical therapy. We also talk about your goals and what is bothering you, because what is bothersome for some people is not bothersome for others. And typically I don't see patients with one complaint only. If something happens in your pelvic floor, and pelvis is very, very tight area, so there's a lot of organs fit in there. So like you have your bladder, you have your uterus, you have your rectum in there, so everything is kind of tightly packed in that area. So what we have, typically patients come in and they have more than one symptom. They're very, very much interconnected, so it takes a little bit of the detective work to see what is a leading problem and kind of causes and affecting other problems. And it kind of all eventually comes together, the picture-wise, between the exam and the conversation with the patient who is answering what is the most bothersome symptom, what kind of problems they have. Like eventually we kind of able to identify a couple of the targets we can address, and a lot of time it's a work in progress. And what we can do for treating these conditions is varies depending on what your goals are and what is the problem you're having. So sometimes it's just, it's going to be as simple as seeing Michele and just working on your pelvic floor muscles, and sometimes it requires surgery, and we do joint surgeries because sometimes patients come in and they not only have like a prolapse issue of the bowel issue, they have some menstrual disorder issues, and me and Dr. Bruckler had a pleasure of operating together. So I always tell my patients, like, if you have some sort of the damage and it requires surgical interventions, like putting a puzzle together, and sometimes it involves hysterectomy, sometimes you can preserve uterus. Like everybody's so different that this is where we're kind of coming up with the unique plan and what we should be doing exactly for you to achieve the goals you need. How can we restore your function? And this is really kind of an interaction between the gynecologist, and because Dr. Bruckler, you've been seeing her for many years, so she knows you on a little different level. I see you as a subspecialist, as a consult. And then I work with Michele because she is doing pelvic floor muscles, and that kind of plays in a role into restoring function as well. So it's complicated, and it's not always just one visit. There's sometimes a follow-up visits involved in that, and it depends how complex the whole issue is. But in the long term, sometimes we involve some hormonal therapies as well, and I do a lot of vaginal estrogen applications. But the hormone therapy, I always establish a regimen which is needed from my standpoint, and then I can refer to Dr. Bruckler, who kind of works on the other issues like hot flashes as well if you're going through the menopause. And I don't know what the percentage of your patients is in that area, and how is the hormone replacement therapy now? Can you talk a little bit? What is the current statement on the hormone replacement?
So, yes, I do have several patients that do desire hormone replacement therapy. I also talk to them about non-hormonal therapy that we can use to help them with their postmenopausal symptoms. So hot flashes, it ranges from hot flashes, not being able to sleep because of the hot flashes, or just menopausal symptoms, as well as vaginal dryness. That's one topic that most people don't want to talk about. They do not have intercourse because everything is dry and painful, so that's something that we sort of talk about during our visit as well. And so, hormone replacement therapy, it's a really long topic, so that takes a while.
Basically, what I wanted to say is there are options.
There are options, and the first thing is talking about it. I think, I have patients that come to me sometimes and they're like, for urinary incontinence, they said, I don't go anywhere. I have to make sure I know where my bathrooms are. I map out every bathroom in the mall. If not, I'm not going. And I said to them, like, this is a quality of life issue. If you are not able to go and do the things that you enjoy, we need to take care of it. So, and that's when I refer to Dr. Lipetskaia or Michele.
And when I see patients like that, I always ask them, how does it affect your life? Because when they come in and they say, like, what's gonna happen if I just leave it alone? I can live with that. My mom lived with that for 20 years. My sister's living with that now. I can probably live with that. So what happens if I just don't do anything? And the first question I ask my patient is, nobody dies of incontinence or prolapse, but people die of depression and lack of exercise. So look at how the symptoms of incontinence or prolapse or bulge coming outside of your vagina and rubbing against your clothes, how do they affect your daily life? So if you say you have a little bit of a leak and you use a pad here and there and you still go to the gym and you exercise, you still go out with your friends, you're not depressed about that and your body image is not affected, then it's maybe okay. If you're not willing to go anywhere, you might have other priorities. You might want to go on cruise instead of seeing me. So if on this other side you feel like you're losing your life because of the symptoms, then yes, they're not going to kill you, but depression can get to you, or inability of having social events can get to you, because your longevity and your well-being is very, very much tied up to how many friends you have, how much of the social support you have. If you becomes more and more isolated and not engaged, then it's probably time to think how I can improve the symptoms so I can get my life back. And this is where it comes kind of to the plan. And then I think the biggest one, if people try to stay conservative, is to when is physical therapy is enough and when physical therapy is not enough. So I'm gonna let Michele and tell you, so she works with the patients, but when do you tell them, I did everything I could and then it's time to go back and see a doctor? So what is it?
If somebody has a stage 3 or beyond prolapse where it's just really not going to respond to strengthening exercises, for example, and prolapse, maybe we should tell everybody what prolapse is when the pelvic organs come down past a certain point where, and they're certainly not living in the home that they used to live in. They're moving down towards the vaginal opening. And sometimes physical therapy can be really helpful in providing some more support in terms of muscular strengthening. And the other thing that I will teach them, or things that I will teach them, are lifestyle factors that they can modify to minimize the pressures that tend to make prolapse worse. So the motto is decrease the pressure from above and increase the strength from below. So let's say I take somebody through a 6-week program and I say, okay, I've taught you everything that I can and you know what you need to do. Carry on with this for a couple more weeks or another month or so, and then if your symptoms are not better to your satisfaction, absolutely go back and see Dr. Lipetskaia. And we talk throughout our sessions, so each time we meet, I'll say, how are things going? Do you feel like things are progressing in the direction that you want them to? Are they meeting your goals? And it may not be a full 6 weeks that I'm working with somebody before we realize that she really needs to go back and see Dr. Lipetskaia before the 6 weeks. So it really depends on that person's goals and how much prolapse, for example, or incontinence or whatever the problem that they're seeing before is affecting their lives. So I always tell them that physical therapy is an interactive thing. It's not something that I do to them when they come in. So it's a team. That person and myself are a team, and we have a lot of things that we need to get accomplished, and they'll only get done if we work together. So it's a very interactive thing, and some women are not prepared for that. They think I'm going to do things to them, and that's going to make them better, but that's not how it is. So anyway, I send them back in that case, too. If that's not something that they didn't realize that that's what they signed up for, then I will send them back. Yeah.
So basically, just the reason is we're talking about that because there is a limit to Michelle's healing powers, and then she reaches that limit. Then patients typically come back to me and say, like, "Okay, I tried," and I always encourage them to go there first because if there's some resources hidden in your own body, you should definitely try to wake them. But sometimes it's just not enough. Like it's. Time took a toll and the area was neglected for a long time. So this is when you're facing choices in terms of for incontinence or prolapse is going to be either medication or surgery, reconstructive surgery. And then we're going deep into that conversation of what kind of surgery is best for you and what order we should do them. And we have this question here is it common to have a weak bladder when you laugh? This is where the complexity of pelvic floor disorders comes in place. So there's several types of incontinence or leakage, and one of them is called stress incontinence, and it's called stress not because you're stressed about that, but because you're producing some sort of activity, like you're laughing, or you're sneezing, or you're jumping, doing trampoline, and it's not really pertinent to age only. It's also can be pertinent to a level of activity, because we did a survey on the young gymnasts, Olympic gymnasts, and 80% of them have stress incontinence. So they do these high impact exercises everybody adores on TV, but they do leak urine when they do them. So it just depends, your bladder can only hold so much of the stress in terms of activity. So likely what the question is about stress incontinence. How common it is pretty common. As I said, if you take I always tell my patients, if I put 10 people from the street, 7 out of 10 of them will have something wrong with their pelvic floor. Either a little bit of a leakage with coughing, laughing, sneezing, or gotta go, cannot make it. Or I just go to the bathroom too soon, or too many times. Or I have something like sensation of a tampon falling out. So it's not uncommon, mostly because women, I think nature did a very poor job designing the outlet, trying for these babies. So, and then the muscle tones and estrogen affection and all that. So it's not uncommon. It's the severity of that and how it affects your life. This is what kind of points towards should you be taking care of that right now, and in what way you should be taking care of that. Is it just more conservative and trying to go for physical therapy, or do you need something if you go through 5-10 pads a day and they're soaking through and you cannot go to gym because of that, and your pelvic floor muscles is weak, then likely Michelle won't be able to do much for you. So we're talking about then on that little device called Pessary, we can do this. There is some over-the-counter version of that. We can talk about them as well, or we're talking about surgical intervention.
So another thing that is important to know is that some of these things that we're talking about, if untreated, like Dr. Lipetskaia said, they're not life-threatening, but they can get worse. Prolapse can get worse. And it's sometimes, and what I tell my patients is, let's address it when you're nice and healthy than when you're 90 and you're not as healthy, because it's only going to continue to affect your life more. And we have another question. So can incontinence that is not addressed lead to prolapse, or are these two conditions unrelated?
So this is what I tell, like, if you have an incontinence, it's not like it's going to cause prolapse, but your chances of developing prolapse are higher. So if you're predisposed to one pelvic floor dysfunction or one type of pelvic floor dysfunction, your chances of you predisposed to the other one are higher as well. So that would be like, if you don't have a symptom yet, it would be a good time, like you're developing one, see your gynecologist or your gynecologist, or see Michelle, just so you don't develop one in the future. Because I can count on my fingers how often I see patients who came there just about when the timing was right, meaning they still have time to work on their muscles to prevent themselves from having the bulge. So I think it's all kind of trying to get away from that stigma associated with pelvic floor dysfunction and seek help rather sooner than later, because the sooner you start looking for help, the less chance that you might need surgery or something drastic to happen. And you can talk to your gynecologist, or you can talk to your pelvic floor therapist, you can take to your family practitioner or your internal medicine doctor. It doesn't matter, you know where to find me.
Right.
And can I say, don't be shy to ask your physician if you are having symptoms of incontinence, or you're having pain with sex, or you're having something that doesn't quite feel right down there. Don't be shy about asking your doctor, and certainly not your gynecologist,
right,
or your urogynecologist.
So
By the time you get to the urogynecologist, the problem is out. But it's so important to just ask the question.
Well, thank you very much for participation. It was a pleasure to have you as an audience, and bye.